Hi, I'm Louise. I'm talking with Jenny Arcalis today. She's a registered nurse with over 20 years experience with home dialysis. Hi, Jenny. Thanks for talking to us today.
Hi, thank you for having me.
Today, we're going to be talking specifically about peritoneal dialysis. So can you tell us what that is?
So, peritoneal dialysis is a type of home dialysis. It's one of two. And this type of dialysis requires a PD catheter insertion in the abdomen. And it's a minor surgery and it's in and out. And after the surgery, the catheter can be used if it's needed to, urgently, within 1 to 2 days. If not, if the patient doesn't require urgent dialysis, then the catheter can be used in about 3 weeks. But in between, we're flushing the catheter every week for 2 weeks, and then we can officially use it on the third week.
When peritoneal dialysis is used, what's happening inside the body?
Okay, so I can show you with this picture. So basically, the filter is a semi-permeable membrane that covers the lining of the internal organs, and it goes all the way up to your diaphragm. And so what it is we put in the special type of solution, which consists of like sugar, salt water, calcium, magnesium, and that helps to filter out the waste products and the excess fluid from the blood side. And that's how the blood gets filtered or cleaned naturally with the solution in the cavity. So you must have solution in the cavity for the blood to get clean. Otherwise, if there is no solution in there, then there's no dialysis or no cleaning of the blood happening. So the catheter itself, it's not in any of the internal organs. It's inserted into the space outside of the internal organs. So it's a coiled catheter that lies in the space, and the end of the catheter is actually deep in the pelvic cavity. So it's like above your or near your bladder area.
You mentioned the filter. What is that?
So the filter is a natural semi-permeable membrane that covers the lining of the internal organs, and it lets certain things pass through, and like fluid, potassium, phosphorus. So again, with the membrane, there's no touching of blood and the PD solution. It's just a surface area where the toxins and fluids come across. Again, this area is highly vascular, meaning there's a lot of blood supply in there, and that's how the blood gets cleaned.
It sounds like then that you're using normal processes in the body to clean the blood. Is that right?
Yes. So normal processes, which is the same concept with hemodialysis, is through osmosis and diffusion. This is always going to be from the blood side coming toward the peritoneal dialysis side.
How does the fluid used in peritoneal dialysis help with osmosis?
So the solution contains glucose, which is going to be the concentration gradient to pull the fluids and the toxins from the blood side. So what happens is, so if you're looking at it, this is the peritoneal cavity side, and this is the blood side. So as the fluid PD solution dwells or stays in the cavity, the sugar gets absorbed into the blood side, and then it draws back the fluid from the blood side and pulls it toward the peritoneal cavity. So over time, that glucose gradient diminishes, so it doesn't pull its, does its job to pull fluid. So after so many hours, when you're dwelling, it doesn't work anymore. So, and that's when patients have to do another exchange to continue that process. So again, with peritoneal dialysis, with CAPD, which is the manual exchanges, they're done 4 times a day, and basically it's breakfast, lunch, dinner, and bedtime. So they're doing a minimum of 4 exchanges a day to clean out their blood and remove the excess amounts of fluid. So when, for example, so let's say they put in there's different volumes of bags, and there's like, let's say they put in 2,000, and they draw out 2,500 cc's, then that's an excess amount removed, which is 500 cc's. So again, these patients, they still have to watch their fluid intake. They can drink up to 1 liter a day, but again, that's going to be, based on every individual. And so certain patients can drink like 4 to 8 cups a day.
For a person who's doing the manual exchanges, what's a typical day like for them? What exactly are they doing? How do they make it work?
So, for example, so we bring them into training, and the training consists of 5 to 15 days. Again, it depends on what they're how much they're retaining, how much they're demonstrating. They have to demonstrate that they can do this safely at home. We tell them that they can do their dialysis, or work it around their lifestyle if they're working or going to school. As long as they do the 4 exchanges a day and they squeeze it in, they can make it work. The exchange itself takes about 30 to 45 minutes to perform. So when you're looking at a bag, I don't know if you can see this, but the bag itself, the setup itself contains a drain bag and a solution bag. So the draining itself, when they drain out the solution, it takes about 20 to 30 minutes. And then filling with solution takes about 10 to 15 minutes. And then they would disconnect from their bag and then cap off with a new cap. And then they would go about their day. So, in between their exchanges, they're doing their business, and then when they're ready to do another exchange, they would repeat the whole process again. So draining, filling, and dwelling. So those are the 3 phases of the CAPD exchange, or the manual exchanges. I would say about 10% of our patients are on the manual exchanges, and then another 85 to 90% are on another type of treatment, which is the nighttime exchanges, which is the nighttime cycler that happens while they're sleeping, and they can be on the machine for about 8 to 10 hours.
If I understand correctly, then the manual exchanges don't require any machine or electricity, but the automatic exchanges do?
Correct. So the manual exchanges are performed by gravity, and the nighttime machine is automated. So the machine actually pushes and pulls the fluid to move the fluid in the machine or the cassette itself.
Can people keep working full-time on peritoneal dialysis?
Yes, they can, and it depends on what their type of job is or their work duties. We try to work with patients to help them, to work as long as possible. We help the patient, determine what their regimen will be like, to work around their work schedule, to make it more convenient and more flexible. So again, it depends with each individual. We work with every patient.
It seems like the manual exchanges would be more difficult to work into a schedule than using the machine at night.
And that's correct. So it would be, more inconvenient for patients to do that type of treatment. And that's why a majority of the patients prefer the machine, but we do make sure that the patient is appropriate for the machine because in which we do a test about 4 to 6 weeks after of starting PD. It's called the equilibration test, and with this test, we're trying to determine what kind of membrane characteristics they have, if they're a low transporter or a high transporter. So that test will tell us how fast the toxins and the sugar and the fluid is coming across of the membrane in a 4-hour period. And that test will help determine what kind of regimen they'll be on. So patients that are actually low, very low transporters would not be a good candidate for the nighttime machine. And that's because they require longer dwell times. And on the machine, they're only on the machine, well, they're on for 8 to 10 hours, but the dwell time is shorter, 1.5 to 2 hours. So they would not benefit from being on the nighttime machine because they wouldn't be able to pull off the fluid or remove the adequate amounts of toxins.
Do people have to go into a clinic for the equilibrium test?
Yes, they do. And it's a 5-hour procedure. So we try to do that again, like 4 to 8 weeks after starting peritoneal dialysis.
What are the requirements for people's homes when they're doing peritoneal dialysis?
So a patient that decides to do peritoneal dialysis, again, it's going to be a discussion between them and their physician if the modality is going to be appropriate for them. So we make that determination before we do a home visit. Again, the type of patient that would choose to do peritoneal dialysis are motivated to be more independent and more flexible with their time. And they're more motivated to be in the home setting. So they choose to do PD. So patients that would not do good on PD would be patients that have had a lot of, stomach surgeries, scar tissue, because all of that scarring would not allow the peritoneal dialysis to work. So when we decide to do PD, the patient's home is going to be assessed during that first week of training. And in the home setting, what we're looking for is the location of where they're going to be performing their dialysis treatments, where they're going to be storing their solutions. We want to make sure that it's in a dry area, not outdoors in direct sunlight, that it's protected from any insects and the weather. And if there's enough space, we also look at that. We look at, the proximity of where they're going to do their hand washing and where they're going to be draining out their solution. So we look at all of those factors. The home doesn't have to be a sterile environment as long as their work area is clean and where they're going to do their exchanges is, going to be organized and, spacious for them to do their dialysis treatments.
How do patients dispose of the fluid once they're finished with their dialysis?
So the effluent or the drained out fluid from the bag will come out clear yellow and it will look like urine. And so they would either hang the bag on an IV pole or on a hook and then put the other end into the toilet or a dirty sink. And then after they drain it out, then they would just kind of disinfect the toilet or the sink.
Can people have pets when they're on peritoneal dialysis?
Yes, patients can still continue to have their pets, but not during the time that they're doing their exchanges. We don't want the pet in and around when they're making the connections and disconnections. But after they're disconnected, then they can have their animal or their pet around. So with peritoneal dialysis, hand washing is very important, masking when they're performing their exchanges. The most important part is the connections, the sterile parts of their equipment, that they don't touch it, drop it, breathe on it. Their environment has to be well controlled. So in an enclosed environment with the door closed, the fan off, the AC off. If there's any drafts coming through the windows, then they would make sure that they close them when they're making the connection and the disconnection. And then once they're connected, then the patient can, open up the fan or the AC and open up the windows for, ventilation. But they just have to remember that, inside is all sterile, and they want to make sure that they keep it like that and don't introduce any kind of germs or bacteria into their cavity.
Do people ever have problems with the catheter itself?
Yes, it's not common, but with the PD catheters, some complications could be migration of the catheter. So instead of being deep in the pelvic cavity, it can move up, higher, and that can affect the flow of fluid coming out. And so if we've tried all of the interventions, then our last resort would be to do an abdominal X-ray to check where the PD catheter tip is in the cavity. And sometimes when a patient is constipated, it can affect the flow of fluid. So we, as much as possible, tell patients to avoid constipation. Of course, infections can be a complication with the catheter, like an exit site infection or peritonitis or tunnel infection around, deep in the tunnel area of the catheter. But with all of these types, we can treat it. We can treat it at home. With peritonitis, we teach patients how to treat themselves with antibiotics in their bag, and they're doing it in the home setting. They don't have to be in the hospital. If they're in a lot of pain, though, then maybe they have to go to the emergency room because, to make sure that there's nothing else going on. And that way they can get some pain medication as well. But other than that, the complications, another one would be like hernia, the outpouching of the intestines or the tissues. Sometimes that doesn't have to be fixed if it's not causing, any kind of pain. But if it's getting bigger and getting worse, then, the doctor might opt to surgically repair it. So with some hernia repair, patients can return to PD after so many days of resting it and, with clearance from the surgeon. But again, that's determined by, the physician or the surgeon based on the severity of the surgery itself. They might not be able to come back. And so with certain conditions, they might require backup hemodialysis temporarily and then come back to PD.
You mentioned the possibility of infections in the catheter, which makes me wonder, can people go swimming? Can they still take showers?
So with PD patients, a lot of them don't want to take that risk of infection. So they give up swimming. However, in my experience, I've had a few that continue to go surfing, continue to go swimming. And that's determining, that's after determining that the exit site is well healed and they're not having any issues. The important thing is that they have to make sure that they clean the exit site and change a dressing right after they come out of the water. Some patients have ordered like ostomy bags for themselves where they could kind of enclose it so it doesn't get wet. But with a PD patient, they can actually take a shower and wet the area as well too. So it's not like they can't wet the area.
Okay. And do patients use any special device to hold the external end of the catheter in place?
So we offer a PD catheter that it's a belt that goes around their waist that holds their catheter in place so it doesn't dangle. And then there's other things out there that that's being offered by other manufacturers that patients would have to pay out of pocket for if they wanted it. But most of the patients usually just tape it down. So the most important thing with peritoneal dialysis is to make sure that the catheter is secured and it's not dangling.
Yeah.
You want to avoid rubbing on the catheter on the exit site to cause any kind of irritation. Avoiding pulling or pulling on the catheter because you don't want to cause any kind of trauma. But again, with the PD catheter, it's kind of like their lifeline. So we teach patients to make sure that they secure it and take care of it for as long as they can.
What are the benefits of peritoneal dialysis compared to other methods of dialysis?
So with PD, it's considered daily dialysis, and it's much, like the functioning of normal kidneys. So you're doing, normal kidneys function 24 hours a day. So, you're getting, good cleaning of your blood. Patients feel better. They have more energy. Their appetite is better. And, in general, they just feel better. With peritoneal dialysis, though, it does preserve the residual renal function, which is, a patient's ability to make urine. So that's one of the benefits. So if a patient can't start with PD, it'll help preserve that function a little bit longer than a patient that would start on hemodialysis. Hemodialysis patients tend to lose that function faster.
Mm. Are there patients for whom peritoneal dialysis is not appropriate?
So when we're assessing patients who are interested, we're asking them personal questions, if, where they live. Again, patient can't be homeless. They need to have a home where they can do their exchanges and store their solutions. If they're living in a 1-story, 2-story, we're looking to see, if the patient needs to go up and down to do their dialysis exchanges. A phone, they need a phone system as well too, so that we can contact them or have access to them when we have questions or need to assess them further. So patients that might not be good candidates, if they are already malnutrition to begin with, then they wouldn't be a good candidate for PD, because with peritoneal dialysis, with each exchange, they're always losing protein. And if they're already malnourished, they're going to lose more protein with their exchanges. So, they might not last too long on peritoneal dialysis because they're getting malnourished.
Mm-hmm. What are the responsibilities that a person takes on when they choose peritoneal dialysis?
They know that they're getting into something where they're going to be responsible for. So they know that they're going to be responsible for doing their own exchanges, adjusting, their diet, their lifestyle accordingly. Their responsibilities are going to be coming to the peritoneal dialysis clinic at least twice a month for blood tests, and they will have their own social worker and dietitian when they come, when they become a home therapy patient. In our program, they're going to be responsible for the inventory of their supplies, ordering their supplies, recording all of their treatments, and making sure that they provide it to their nurse on a monthly basis. Patients they're going to receive shots every 2 weeks or every 4 weeks, depending on what their blood work is. Dialysis patients, because their kidneys are no longer working, they would depend on these medications to stimulate the bone marrow to make red blood cells. So with dialysis patients, they're normally anemic. Their red blood cell counts are low, their iron counts are low. So this shot is it's called the erythropoietin stimulating agent shot that's given every 2 to 4 weeks to stimulate the bone marrow to make those red blood cells. So again, patients are not going to feel as tired. They're going to be more energetic.
How are people trained to do their own peritoneal dialysis?
So patients that choose to do PD, if they're pretty independent and capable, everything is going to be hands-on. Once they start training, we demonstrate a lot of things. And so we demonstrate the exchanges and the administration of antibiotics into the bag. So they have to make sure they can demonstrate everything that we teach them safely. Patients would require, good vision, good hand dexterity. They also need to demonstrate, good judgment, good decision making, because they need to make sure that they can, call the nurse when they're having a problem. Patients, during training, we're assessing the patient, we're assessing to see if they can make those types of decisions, also making sure that they're not forgetting every step that we teach them. If you're, a patient that might be having, early signs of dementia, they might not be a good candidate or, to do peritoneal dialysis because they will forget, to do the treatments and, their overall care. So again, good critical thinking as well too. So all of that is taken into consideration in training. And if the patient demonstrates that they can't take care of themselves, then we would ask to see if there would be another family member that would take over. Or if they're already an established patient and there's changes in their condition, maybe like a heart attack or a stroke or a amputation where it would affect their ability to do peritoneal dialysis, then, we would step in and say, is there another family member that can do the PD for you? If not, then we would have to transfer the patient to hemodialysis in center. So things like that. Another reason why we would send patients over to in-center dialysis would be if they're having an infection, and that's the number one reason why patients would switch over if the infection was one that could not be resolved immediately. So things like fungal infections or like a Pseudomonas infection.
You're making me wonder if someone who's using peritoneal dialysis needs to go into the hospital for some other reason. Does the hospital offer peritoneal dialysis, or do they have to then go on to hemodialysis while they're in the hospital?
So patients that end up in the hospital, they would still continue to do their peritoneal dialysis. The hospital would provide the supplies, and the staff would be able to perform their treatment. So the patients wouldn't require to bring in their own supplies. The hospital would provide those supplies for them.
Cool.
Yep.
What support is available to patients, both when they're first considering peritoneal dialysis and then when they're using peritoneal dialysis at home?
So patients have access to our dietitian and social worker for support, and the nurses. If you're a PD patient on the machine, there's technical support 24 hours a day. And if you're, well, any kind of PD patient, we have an on-call nurse available 24 hours or after hours and on the weekends for support. So if a patient calls and if they have questions, the nurse can, answer those questions. And if the patient's having problems and the nurse determines that he or she needs to go see that patient, then they would meet up at the clinic, or she would go to the home to see what's going on.
You mentioned dwell time when discussing the permeability test. What's dwell time?
So dwell time is the time that you leave the solution in the cavity. So the dwell time can be a minimum of 2 to 10 hours, depending on what type of solution you're using. So, but we say no longer than 8 hours. With the other type of solution where it can stay in 8 to 16 hours, it's called extraneal solution. And that's a solution that's not sugar-based, and that's prescribed by the physician. So that one can stay a little bit longer, but the glucose-based solutions usually say not to leave it in more than 8 hours. But again, it depends on what your membrane characteristics are. Some patients shouldn't really be leaving it in for more than 2 to 4 hours, because otherwise it gets reabsorbed back into the body. Like, it doesn't do its job to remove fluid. What happens is they don't remove all of the fluid that they put in. So let's say they put in an amount of 2,000, but only like 1,500 comes out. Then the longer you leave it in, the more it gets reabsorbed into the body. And I just want to mention that for patients that are diabetics, blood sugar control is very important, because that can affect the reabsorption of the fluid into the body. If the blood side of the serum, your blood sugar levels are greater than 250, 300, or 400, then the solution is not going to do its job to pull off the fluids from the body. Right. So it's going to, instead of pulling one way, it's going to pull back the other way. Yeah.
That would not be good. Yeah. Speaking of time limits for how long the dialysis fluid stays in the body, at the end of each session, does a person completely empty all the fluid from their abdominal cavity?
Yes. So a patient knows, they know when they are completely empty, either by time. So patients will know how long it takes to drain themselves out of the fluid. So again, some patients may drain out in 20 minutes, some may require 30 minutes. So patients are taught, how to look at the fluid, and they can actually look at the drain bag and see the flow of fluid. So, once it starts trickling, then it's slowing, the flow is slowing down. And so that's like an indication that they're done emptying the cavity.
You mentioned CAPD and APD. Can you tell us what those acronyms stand for?
So CAPD stands for continuous ambulatory peritoneal dialysis, and APD is automated peritoneal dialysis. So the automated peritoneal dialysis can also be referred to as CCPD, continuous cycling peritoneal dialysis. So So CAPD is the manual exchanges that are done 4 times a day, and the automated is the nighttime machine.
How long is the external part of the catheter that sticks out of the body?
So the catheter itself sticks out about 6 to 12 inches outside of the abdomen. And then, of course, internally, it's a longer length inside, a coiled catheter that's inside the cavity. For as long as a patient takes care of it, it's a lifetime catheter, a permanent catheter, for as long as a patient takes care of it. If there's complications, that's the only time a surgeon might have to go back in to either remove it or change it. Um, and usually change the exit site location or the tunnel area.
Mm-hmm.
So I've seen patients be on PD for 15 to 20 years for as long as they take care of themselves.
One question I have, since people are putting a fair amount of fluid into their abdomen, do they feel any differently? Do they have to wear bigger clothes? I mean, what's the experience like?
When we're putting in fluid, a patient is putting in about 3 to 5 pounds of fluid. They're carrying that amount of fluid in their abdomen. It can make you feel full and a little discomfort, but over time, a patient gets used to that feeling. A patient can gain body weight over time because of the sugar in the solution, the extra calories. It's like eating a piece of cake with every exchange or every treatment. So, of course, a patient needs to be mindful of their carbohydrate intake if they don't want to lose or gain too much weight over time. So, again, if a patient feels full, then they're gonna have to eat more, maybe more frequent meals, maybe 4 to 6 times in between to not feel as full or uncomfortable. So we do the volume that's put into a patient is going to be based on their height and their weight. So we have different volumes of or different volumes of bags. So our smallest bag is a 1500 cc bag or a 1.5 liter bag. The next one up is a 2 liter bag, 2.5 liter, 3 liter. The 3 liters are the biggest volume that we have. So that would be more for our bigger patients that would require more cleaning, more dialysis.
What general advice do you have for anyone who may be considering peritoneal dialysis?
So if a patient knows that their kidneys are failing, they've been diagnosed with chronic kidney disease. So sometimes patients know that they're in chronic kidney disease like several years out. So my advice is to make sure that they see their doctor regularly to make sure that they get those blood tests done, because the blood tests will help analyze how the functioning of the kidneys are, if it's progressing or staying about the same. So as patients progress toward end stage renal disease or kidney failure, they're gonna they might not feel it in the beginning, but in the end, when they start to get really tired, weak, sick, maybe nauseated, vomiting, headaches, blood pressures going up higher. So those are the signs of uremia. All I advise is to make sure that they go see their doctor right away with their symptoms. Don't delay any kind of medical treatment, because that's important. You don't want to be end up in the emergency room, with kidney failure and having to start emergency dialysis. So usually when patients are gathering information and educating themselves about what type of dialysis they want, we generally tell them to make a decision. So they have to know what their kidney function is, and what that number is. So they refer that number as the GFR, which is the glomerular filtration rate. So at a rate of 20% functioning, that's when we want patients to make a decision about what their option will be, or choose an option. Um, you know, once you start to progress toward end stage renal disease, again, you don't want to wait too long to start dialysis either, too. So usually when that number falls below 15 is when patients need to start dialysis. But sometimes, patients are not symptomatic, and so they might fall, below, even that more further down, like 10, and they might still feel okay, but again, the doctor will, go with what type of symptoms you're having, if they're severe or not, or so again, just make sure that they have that open communication with their physician.
Thank you so much for taking the time to talk to us about peritoneal dialysis.
Thank you for having this opportunity.